Bismillahirrahmanirrahim. Dr. Arif Zaheer, Professor of Pediatrics, PGMI, Amiruddin Medical College, Lahore General Hospital. Today's presentation is for 4th year MBBS class. We start with a clinical scenario. A 12 years old child has fever for the last 10 days and he had diarrhea for the initial 2 days but now has become constipated. On examination, he appears sick and is running a temperature of 103 degree Fahrenheit. The liver and spleen are palpable about 2 to 3 centimeters below the costal margin, and he also has abdominal tenderness and a macular-papular rash on the lower chest and the abdomen. The CBC shows leukopenia. The various questions which can be asked about this scenario, they are: what is the most likely diagnosis? What are the other clinical features of the disease? How will you investigate this patient and give a plan of treatment and enumerate the complication of the disease? So these are the various questions which may be asked after reading this scenario. Now, if you look at this scenario and analyze it, you can see that this child is having fever for the last 10 days. There is history of some abdominal symptoms like diarrhea and constipation, and then the tenderness. And on further examination, the spleen and liver are palpable. And there is another peculiar feature, which is maculopapular rash, which is present on the lower chest and abdomen, and moreover, the labs show leukopenia. So these points, that is 10 days history of fever with abdominal symptoms and then abdominal tenderness, palpable liver and spleen, and a macular-papular rash along with leukopenia. These findings, they favor the diagnosis of a condition which is known as enteric fever. So we proceed to the next slide. Now, our learning objectives of this presentation are that by the end of this lecture, you will know the important statistics about enteric fever, the etiology of enteric fever, the mode of spread, the clinical features, the investigations of the enteric fever, the treatment of enteric fever, the complications of enteric fever, and how can we prevent enteric fever by adopting various preventive measures and by using the available vaccines. Now, what is enteric fever? This enteric fever encompasses two important diseases. One is typhoid fever and the other is paratyphoid fever. The term enteric fever and the typhoid fever, they are used interchangeably or synonymously. Now, the Salmonella enterica, also known as Salmonella typhi or Salmonella typhimurium, causes a disease which is called typhoid fever. The Salmonella enterica or Salmonella typhi is a gram-negative bacillus. Salmonella paratyphi A, B, and C, they cause a disease of milder intensity, and it is known as paratyphoid. The typhoid fever is more common as compared to the paratyphoid fever. Then the ratio of the disease caused by Salmonella typhi to that caused by Salmonella paratyphi is 10:1. The organism has certain antigens which are O antigen, which is known as somatic antigen. Then we have the H antigen, which is flagellar antigen, and then VI antigen. This VI antigen is basically the main virulence factor of this organism. The other factors which predispose a person to typhoid fever are the age of the child and the immunity status of the patient. The incidence of this disease in the developed countries is 15 cases per 100,000 population, while in the developing countries it is relatively more common, and the incidence is 100 to 1,000 cases per 100,000 population. Worldwide, there are about 27 million cases and 200,000 deaths annually. Now, the problem which are we facing nowadays is the development of drug resistance. So, there is the resistance is developing against commonly used drugs, and this is going to create problem in the near future as well. Now, the mode of spread. How does the Salmonella typhi spread and cause the disease? Now, the first mode of spread is direct and indirect contact of the person with the patient or a carrier, which are generally food handlers. Now, ingestion of the food or water which is contaminated with Salmonella typhi or which is contaminated with human feces can spread the disease, because this organism is excreted in the feces of the carriers and the patients. Now, various seafoods like shellfish, oyster, which is cultivated in contaminated water, can also spread the disease. Similarly, the use of night soil as a fertilizer can spread the disease in the community. The incubation period of this disease is 7 to 14 days. And as far as the infecting dose is concerned, the infecting dose which has been mentioned in the textbooks is the in the range of 10 raised to the power 5 to 10 raised to the power 9. So when this amount of organism is ingested, it can cause disease in the vulnerable hosts. So this is the picture of Salmonella typhi. It belongs to the genus Enterobacteriaceae. It is a facultative anaerobe, gram-negative rods, non-spore forming, and it can be distinguished from other bacteria by its peculiar biochemical features and antigenic structure. Pathogenesis of the typhoid fever. Once the Salmonella typhi is ingested in the contaminated water or food, the Salmonella typhi invades the small intestine and enters the bloodstream. This is known as primary bacteremia, At this moment, the patient does not have any signs and symptoms. These organisms are then carried by the white blood cells to the various organs of the body known as reticuloendothelial system, and that includes liver, spleen, and bone marrow. At these sites, these organisms multiply and their number is increased, and then they re-enter the bloodstream, and this is known as secondary bacteremia. And at this stage the patient starts showing the signs and symptoms of the disease. So this marks the end of incubation period. No, during this secondary bacteremia, multiple organs are invaded by the organism, including gallbladder, biliary system, and the lymphatic system or lymphatic tissues of the bowel, and they multiply at these areas. The organisms present in the gallbladder and biliary system, they are excreted in the feces, and they can spread the disease in the community. Now, as far as the involvement of the lymphoid tissue is concerned, when the organisms through the bloodstream reach the bowel, they initiate an intense inflammatory response in the mucosa and as well as in the lymphoid tissues. The mucosa gets inflamed, and in some cases the inflammatory process may involve the muscularis and serosa of the gut and can cause the perforation of the intestines. The inflammation at the level of lymphoid tissues or the Peyer's patches may cause necrosis and sloughing of the uh, Peyer's patches. That will lead to ulcer formation, which can bleed heavily and can cause per-rectal bleed in some of the patients. The perforation and the bleeding per rectum are now rare, and they are seen in less than 1% of the patients. The organisms, they can be identified for diagnosis in the cultures from the stool. The incubation period I have already discussed. It is 10 to 14 days. It may be as short as 3 days or as long as 21 days, depending upon the dose of bacilli ingested by the person. Clinical features, they vary depending upon the period of illness. In the first week, the patients have malaise, they can have headache, cough, sore throat. The disease classically presents with step-ladder fashion rise in temperature, or in pediatric population, this finding may not be there. And then the patient will have abdominal pain, constipation, and they will have diarrhea. In the second week, the patient will have um, जी शोर आ रहा है मैं ना एक रिकॉर्ड कर रहे हैं एक लेक्चर शोर आ रहा है In the second week, the child will have mild hepatosplenomegaly and they can have relative bradycardia. The rose spots, which are the maculopapular rash, may be seen on the lower part of the chest and the abdomen. These are small reddish spots which generally last not more than 2 to 3 days. In the third week, if the patient is not managed properly, the patient can develop the complications of the illness. He will become apathetic, will appear more toxic. He may become delirious, disoriented, and he may develop diarrhea or may develop bleeding per rectum, and very rarely the patient can develop perforation of the intestine leading to peritonitis. And if the patient develops peritonitis, the abdomen will be very tender, tense, and the bowel sounds may be absent. So in such cases, the X-ray abdomen may be helpful in the diagnosis. In case of perforation, you will see air under the diaphragm when the X-ray is taken in the erect posture. Other complications of this disease which can arise in the third week include hepatitis, pneumonia, thrombophlebitis, myocarditis, cholecystitis, nephritis, and of course the osteomyelitis and CNS complications like psychosis and many other complications which will be enumerated later on. 2 to 5% of the patient become gallbladder carriers, and of course if they are food handlers, they can spread the disease in the community. Now, this slide shows the ratio of different clinical features, clinical signs and symptoms of the disease. So high-grade fever is present in more than 95% of the patient, the coated tongue in 76% of the patient, 70% of the patients are anorexic, 39% of the patient may vomit, and the hepatomegaly is seen in cases in 37% of the cases. Diarrhea is present in 36% of the patients, and 29% of the patient appear sick and toxic. Abdominal pain is present in 21% of the patient. 20% of the patients are pale. Splenomegaly is found in 17% of the cases, and the constipation and headache are found in 7% and 4% of the cases respectively. So the fever is almost present in every patient. Then they have coated tongue, they have visceromegaly and abdominal symptoms like abdominal pain. The diagnosis of this condition, the mainstay of diagnosis is still clinical despite of new innovations in the diagnosis. The CBC will show leukopenia or it may be normal. Similarly, in very sick patients, there may be thrombocytopenia. Then the other investigations which can help in the diagnosis include blood culture, stool and urine culture, the bone marrow culture, then liver function tests, WIDAL tests, TYPHIDOT test, and a new test which can detect the organism much earlier is known as polymerase chain reaction. Now, as far as the blood culture is concerned, 5 to 10 ml blood is collected and it is inoculated in 50 to 100 ml bile broth. Subcultures are done on Econke's agar, which is a selective media for Salmonella typhi. So this is a blood culture bottle and we add 5 to 10 ml of blood in the bottle and then we incubate this on a specific culture medium. The blood culture is positive in about 90% of the patients in the first week, in about 75% of the patients in the second week, and 60% of the patient in the third week, and 25% of the patient in the fourth week. So the yield is maximum in the first week, and the blood culture is a very specific test and diagnostic test of Salmonella typhi. So on an average, the blood culture is positive in 60 to 80% of the cases. The organism can be identified by its specific reactions, that is biochemical reactions. For example, it is a non-lactose fermenter, it is a non-motile, non-spore forming, indole positive, urease negative, and it can ferment glucose, mannitol, and maltose, but cannot ferment sucrose and lactose. It is a facultative anaerobic organism. The other samples for cultures include urine culture, stool culture, and urine and stool culture may be positive in the second week of illness. And of course, the bone marrow culture. Bone marrow culture is a very sensitive test for the detection of Salmonella typhi, but as it is an invasive test, so it is not generally performed in the laboratory. Now, the very popular test in the past was WIDAL test. It is nowadays obsolete and is not frequently done for the diagnosis of enteric fever because it lacks sensitivity and specificity. By that I mean that it may be false positive or it may be false negative. Now, what the WIDAL test is, that the WIDAL test detects the antibodies against the O and H antigens of the organism. 2 serum specimens are obtained at interval of 7 to 10 days to detect the rise in the body, rise in the antibodies. The rising trend in the antibodies titer is helpful in the diagnosis of typhoid fever. Serial dilutions are tested against the antigen. False positive and false negative results, they limit its utility, and falling titers of antibodies against the antigens are significant. If the O antibodies are detectable in a dilution of 1 in 160, then this may be significant. Similarly, the antibodies against flagellar antigen in a dilution of 1 in 320, they are definitely significant. 2 samples must be tested, that is known as paired serum, and a rise in the antibody titers carries significance. Then there is another test which is known as TYPHIDOT. TYPHIDOT is a test that consists of ELISA technique, and it detects IgM and IgG antibodies against the outer membrane protein of the Salmonella typhi. This TYPHIDOT test becomes positive within 2 to 3 days of infection, so it can help in the early diagnosis of the disease. The PCR test, polymerase chain reaction, has been used to amplify the specific genes of the Salmonella typhi. So it is a very promising mean of making a diagnosis, and it can detect very low level of bacteremia. So it is helpful in the early diagnosis of the typhoid fever, but it is not freely available, and moreover its cost is also a big factor, uh, which uh, makes the patient unable to get this test done in the laboratory. Now, the treatment of this fever is sportive, and then, of course, the pharmacological treatment. The antibiotics are the mainstay of the treatment of this condition. We give antibiotics to the patient to relieve the fever, which may be paracetamol or ibuprofen, can be given orally or patient should be given soft, easily digestible and palatable diet. Then, as I have said, that the organisms have become resistant to the traditionally used antibiotics like chloramphenicol, amoxicillin or ampicillin, and the combination of trimethoprim and sulfamethoxazole. So these drugs are no longer used as empirical therapy for this condition. Generally, we start with third generation cephalosporins or quinolones. Third generation cephalosporins include ceftriaxone and cefotaxime, and the quinolones include ciprofloxacin, ofloxacin, etc. The problem which we are facing nowadays is that some of the patients have become resistant to even third generation cephalosporins and quinolones. So in such cases, we have to switch over to new drugs like azithromycin and meropenem or imipenem. Steroids are generally not required, but in certain situations we have to use dexamethasone. For example, in a very critical sick patient or in a patient who is having abdominal tenderness and there are chances of perforation, then the patients who have CNS symptoms like psychosis, like GB syndrome, like transverse myelitis, psychosis, etc., or they have other complications like myocarditis, like nephritis. So in some situations we have to use steroids, particularly the dexamethasone. So initial dose is very high, 3 milligram per kg is given stat, and then we have to repeat this dexamethasone in a dose of 1 milligram per kg every 6 hours. Prevention is through drinking safe water and then avoid street foods, especially ice creams, cut fruits, etc., because they might have been contaminated by the Salmonella typhi and can cause the disease. The food handlers should be detected, and if they are asymptomatic carriers of the organism, they must be treated before they start working in food industry or restaurants. Now, as far as the vaccines are concerned, there are two types of vaccines available. One is the oral vaccine and the other is injectable vaccine. Oral vaccine is rarely used, and it is nowadays not available. The only vaccine which we use is the injectable vaccine, which is prepared against the VI capsular polysaccharide of the organism. It is given intramuscularly, and we have to repeat this vaccine again after every 2 years. So we have to give a booster dose of typhoid vaccine. Complications of the disease. The most common complications of the disease are the gut perforation, bleeding from the intestines, and some of the CNS conditions like enteric encephalopathy. In order to memorize the complications, we can divide them into various systems like CNS complications, for example, encephalopathy, cerebral edema, cerebral abscess, meningitis, ataxia, GB syndrome, and psychosis. Now, the cardiovascular complications are endocarditis, myocarditis, pericarditis, and congestive cardiac failure resulting from myocarditis. Then we have certain pulmonary complications like pneumonia, bronchitis. Bones and joints may be affected, and a patient can have osteomyelitis, septic arthritis. The hepatobiliary system, there may be cholecystitis, hepatitis, and hepatic abscess or peritonitis. As far as the hepatitis is concerned, generally during enteric fever or typhoid fever, there is some disturbance of the hepatic enzymes. But in case of hepatitis, the bilirubin will be markedly elevated along with the liver enzymes. So hepatitis is a known complication of typhoid fever, and in cases of perforation, the patient will develop peritonitis, will become more sick, abdomen will become painful, so there will be tenderness, and later on the patient will develop guarding and rigidity of the abdomen, bowel sounds will be absent. So these patients will have to be managed by the physician as well as by the surgeon and should be properly investigated. Then in the GIT there will be perforation and bleeding. These are the two complications which are nowadays these are seen rarely because the condition is diagnosed much earlier and is treated promptly. So as a result, the complications of the typhoid fever generally they have decreased in their incidence. With that, we come to the end of our today's lecture, and I thank you all for your patient listening. And